management of massive PPH. Currently, most of the algorithms, when you look at the advanced obstetric life support, the also course, the prompt course, they all following the Dr. ABCD approach, which I feel does not address the immediate danger to the woman who's bleeding, which is equated to similar to a bleeding limb, where we are supposed to tourniquet the uterus before we really then can support the airway and breathing. Most of the women who are bleeding are very young and are likely to maintain their AB, and circulation is the biggest problem. We're going to talk about the Global Emergency Care Training, OMG, which is very important to reduce PPH. And this involves from the lowest carer to the highest carer of delivering women. The approach to early management of PPH. I'll talk a bit about the sister match or T approach, which is equated to the Dr. CABCDE approach, which you use in trauma, which I feel addresses the real algorithm as well as also drills we should use in PPH. I'll also talk a bit about early procedural management of PPH, which should be implemented early to prevent massive PPH, and delayed management will then compromise the woman. I'll talk a bit about blood replacement after PPH, blood bank management, mostly looking at the low-resourced countries, how we can improve on the availability of blood, and more so what I call the walking blood bank in the remote and poorly resourced areas. On the last note, I'll talk about the live drones. We're hoping that one day we'll get more live drones delivering blood to the low-resourced areas, taking it from the drones which are being used to drop bombs. Instead of bombs, we'll be dropping blood, which is life-saving. My talk involves a lot of collaboration between the midwifery training, the basic and advanced diploma training, the family medicine training, as well as also the specialist training in obstetrics and gynecology. Currently, we do have a situation where we've got the midwives, they work with general medical officers in rural and remote places. In the cities, you'll find you have the midwives, the registrar in between, as well as also the obstetric gurus at the top. There seem to be a bit of deficiency of the training in between the rural remote area and the big cities, because we lack the middle class or middle training individuals. And that's where I feel low-resourced countries could benefit from combining the family medicine training, the midwifery training, with the critical training which is needed in managing obstetric patients, which is anesthetics, obstetrics, and procedural obstetrics, which I feel midwives can easily be taught to do anesthetics, to do procedural obstetrics, which has been done in Africa, which we call clinical officers. And with that, you add on an advanced diploma in obstetric training, which can be offered to advanced trained midwives, family medicine physicians, and that would bridge the gap between the obstetric specialists and the lower trained cadre. And that opens up the ladder to train to the higher level of care, which is the maternal-fetal medicine specialist. That was just a digression, but that is very important in managing PPH. My talk will really compare between the highly resourced and the lowly resourced countries. When you look at the woman who is in the lowly resourced country and the one who is in the highly resourced country, there are differences really on how much resources they are provided during their pregnancy and during their perinatal period. As you can see, the woman in Africa is more worried about putting food on the table for the children during their pregnancy, and they're still carrying their pregnancy and having to do the duties. And they might miss the antenatal clinic, or they might not go because of distance, and then the planning for the possible PPH is delayed. Whereas the woman in the well-resourced country has got just an awash of all resources around them, even being taught what to do during their pregnancy. When you compare the maternal death contribution for African countries, it's 48% of the world maternal death, which is very high. Lifetime risk of a woman dying of pregnancy-related complications in Africa is 1 in 20. The maternal mortality rate in some countries in Africa is ranging between 600 and 830. And the difference between the two resource, the low resource and high resource countries, basically the amount of money which is put in managing complications. PPH happens in all countries, but it's how we manage them or how we try and prevent them which will make a difference for the ladies. Maternal death in well-resourced countries is as low as 0.5% of the global contribution. Lifetime risk is 1 in 2,500, which means 100-fold less than the woman in Africa if you put them side by side. And the maternal mortality rate is 9 per 100,000 in Australia, which is less than 100 folds. What kills women in childbearing age is mainly the hemorrhage, the ruptured ectopic ruptured uterus, PPH, and you might get shock and sepsis during the whole management of the complications. When you look at the biggest cause of death in childbearing age women, hemorrhage is still leading. So that's hence they need to talk a lot about how to manage hemorrhage. When you look at what is going to kill the woman quickly, postpartum hemorrhage would kill you in 2 hours, antepartum hemorrhage in 12 hours, obstructed labor 2 days, infection 6 days, HIV 15 years. But when you look at the resources which have been put into managing HIV and recently COVID, when you compare to the amount of money which is put in postpartum hemorrhage, it just shows that postpartum hemorrhage is not getting adequate attention, yet it kills more women than COVID and HIV maybe combined. Coming to the approach to managing a woman who has got a massive PPH, this is usually from 1,000 mils up. We know the definition is between 500 and 1,000 is mild PPH, 1,000 to 1,500 moderate, more than 1,500 to 200. 2,000 is severe, and more than 2,000 is what we call extreme or sanguinating hemorrhage. The system HOT approach really addresses what we should do when the woman starts oozing or bleeding on you. The first thing is to shout for response. The woman will respond to you, then you know A, B is fine. And that shouting for response is also going to call for more help, either by pressing your emergency bell or even literally shouting to call other people to come and help you. And soon after doing that, the first thing that should happen is mainly to compress the uterus, wrap up the fundus, compress the uterus, then give orders for people to give the medication which are going to help with the medical compression of that uterus, which are the uterine tonics. This is equated to applying a tourniquet to a bleeding limb, which is closing the tape. If we don't do that quickly, the uterus is actually receiving between 300 to 500 mils per minute soon after the placenta has come off. So if you take time trying to put oxygen on the patient, trying to put IV access, if you don't finish within 5 minutes, you already have 1,500 mils on the floor from that woman. Yet if somebody compresses that uterus, you reduce the amount of bleeding dramatically while you're allowing your uterine tonics to work. This works by basically physically compressing your spiral uterine arteries to stop bleeding, and that way you actually prevent the gravity of that PPH. We don't forget about airway support, breathing, as well as also getting IV access, giving other drugs, the infusion, your oxytocin infusion, tranexamic acid, as well as also The H is for temperature control, which is hypothermia prevention. As you know, hypothermia, acidosis, and hypotension are the biggest killers of patients if you relate that to trauma. OT stands for early mobilization of theater team, early mobilization of the senior staff to assist with the procedural skills to help this lady. Early use of Bakri balloons, intrauterine tamponade, even using a condom and catheter would help many women. The fist in the vagina compressing the uterus is sort of the ideal thing to do, but not every woman has got adequate epidural, and that would be quite painful. So the modified way is you put a gauze between you on your fingers, try and get your hand inside, press the cervix, and then you rub the fundus up. It would give you adequate compression without giving you a lot of pain for the ladies who don't have epidural. For those who have got an epidural, it's decided and it's working. Manual compression would stop the bleeding as quick and would give you time for the oxytocin to work. Oxytocin given IM 10 units will take about 3 minutes to start working. Igometrin takes about 10 minutes to 15 minutes. So you can imagine if you're just using your uterotonics alone without bimanual compression, 3 minutes will go before that uterus really start contracting. So it's important to use the manual, rub up, compress, and buy time while you get all the other resources in. That is just a reminder of the commonest causes of PPH, tone being the most cause, and hence our emphasis on compressing that uterus. That's your manual tone which you're putting in, while it's allowing the uterus itself to recoil and compress the spiral uterine arteries. If the bleeding continues after all your measures to try and manually compress, give you teratonics, remember to use the intrauterine tamponade, which is the Bakri balloon. In well-resourced countries, that's what is available. But you can actually make a similar balloon from putting a condom on top of a 24F catheter and inflating that condom with water, and you can still get the same tamponade. The golden hour in PPH management is really split into the golden first 5 minutes, the golden 10 minutes, 30 minutes, and the hour. The first 5 minutes really is uterine compression, uterotonics, rub up that uterus. Then after that, you get your infusions on extra medication, your tranexamic acid. And if you're getting to about 30 minutes without really controlling your bleeding, you really need to think about theater. And the first hour is all about getting all the surgical management done within that hour if the woman is still bleeding. Those are the other mechanical ways operative to try and stop the bleeding, the B-lynch, but that is done in an operative theater. Easy to apply if it is PPH soon after cesarean section, but if it's PPH from a vaginal delivery, manual compression can actually buy you time, can actually stop you from going to theater because you've managed that PPH, as well as also you can put the Bakri balloon. Bakri balloon has actually reduced the need for open operative management of PPH drastically. So countries without Bakri balloons, think about the condom and catheter. It's a size 24 catheter. You roll the condom on top, tie the condom with a silk suture. You will be able to inflate that in the uterus and to get the same compression. A brief overview of the anatomy for the young clinicians who do operative surgery but don't do enough hysterectomies. We teach them to go for the uterine artery ligatures, which I'll show in the next slide. Using this anatomy, you sort of realize why we're going below and up to try and sanguinate the amount of blood which is going to that uterus. So you tie your uterine artery just above where it bifurcates into the uterine limb and the vaginal limb, as well as also your supply from the ovarian artery. That will then starve that uterus of the blood and reduce the amount of blood you're losing. And that way you'll be able to save this lady, as well as also save their uterus, especially if they are still young and still want to have some more children. Hysterectomy is sort of the ultimate way of managing severe PPH, but it's rarely being done these days because of the efficacy of the intrauterine balloons, the efficacy of the medicine we're using in our third stage of management, early management of the PPH, the bimanual compression will be able to then avoid cesarean sections. I'll move on to the next part of my talk. This is about blood transfusion. And like I said, I hope one day we'll have the drones which will be flying and dropping blood to the area where you need them, which is the rural and remote place, who has got that bleeding woman with a PPH, but did not have adequate blood in their blood bank. You push in 6 units with a drone in and out 200 kilometers. I think that will be more life-saving than what is happening now. The world is pushing big bombs in drones to kill each other. It's every maternity unit to be, their wish is to have blood bank available on their side, but there are some places where the blood bank is either limited or there is none at all, especially in the low-resourced countries, rural areas, developing countries. I then have been working on how best can we get blood in the low-resourced areas without the cost of the current component bloods which we're having. Now, comparing whole blood versus the component pegged red cells to look at its shelf life. Whole blood can be kept at 4 degrees for 35 days. The pegged red cells, 52 days at 4 degrees. So why are we using a lot of money separating the components, taking the blood to centralized blood banks away from the rural and remote areas, and then try to transport them back in different components, which is pegged cells, platelets, plasma. Yet we're saying the best way to replace blood at the moment is to the 1-to-1-to-1 component ratio, which we can easily get from the whole blood because it's already combined for us, and that's the best way to get that 1-to-1-to-1 ratio. So a whole blood bank is the way, as far as I'm concerned, to retransfuse the woman who's bled, especially in your low-resource areas where you don't have the high-tech tag or rotem to really calculate which component you need to be replacing. The evidence-based approach is now pushing for the rotem and tag, but we know that most of our rural and remote places do not have that access, and the machines are also very expensive. It is my wish that one day we'll have what I call the community working blood bank. This is taken from the military way of how they transfuse their injured soldiers away from their best hospitals where they might not get adequate blood bank. They use actually the other soldiers as the blood bank. Everyone is grouped and screened and typed. And if you do get someone injured, it's a matter of looking for the O negative soldiers around, you bleed them and you transfuse that person. The same can be applied to the low-resourced country, rural and remote woman who is pregnant. During that 9 months, we can look at the relatives around her and other villagers, try and match her to 1 or 2 people. The day she comes in labor, we call the matched relatives or community to come and donate 2 or 3 units of whole blood, which can be kept in the fridge at 4 degrees while she's having a labor. If she doesn't use them because she's not had a PPH, that blood can then be pushed to the central blood bank. But if she does bleed, we know we've got 2 to 3 units of whole blood freshly collected that day to be used, which will be very, very efficient. Even if there is an unfortunate situation of transmitting one of the viruses, blood-borne viruses, during that time, most of the blood-borne viruses now, we do have adequate antiretrovirals to treat for both Hep B, Hep C, and HIV, and still achieve 90 to 80% of someone's life expectancy of those medications. So the fear of the blood-borne viruses is getting less and less, and more women will die if they're not transfused than those who die if they are transfused virally infected blood, because we're trying to save their life from PPH. So the community blood bank would be done by grouping and antibody screening the people or cohort of people around that lady who's in the pregnancy in their 35 to 37 weeks of just age. It's borrowed from, like I said, the US military field combat blood bank system they were using. All blood is collected and stored freshly. It can be stored for about 10 days. If it's not used, then you can then send it to the central blood bank for component separation, and can be stored even longer. It relies on community trust and modernized togetherness, use of mobile phones, use of solar-powered fridges, which can then store that blood at 4 degrees. The drawbacks, of course, is the religion. There are those who don't believe in getting blood transfusion. There are some who say they don't want blood from someone else, and also the fear of the blood-borne viruses. But like I said, we now have enough antiretrovirals to really counter those fears. Most blood-borne viruses, like I said, don't kill someone quicker than PPH. They take years, 7 years, 10 years, 15 years. PPH kills women in two hours. So it is my hope one day we have a working blood bank with adequate live drones to transport that blood to where it's needed, and to be able to save more women who would have died from PPH because there's not enough blood to transfuse them. Maternal PPH, lives saved equal more economic lives saved. So we need to educate our people and build skills in early PPH management, the bimanual compression, reduce the number of people who are going to die of PPH. We have more blood, working blood banks in low and low resourced rural and remote places. That way we'll be able to break the vicious cycle, which is killing women from bleeding. I've written an article on PPH drills and skills building based on this above concept, and you can find it on internet if you Google. I thank you.